Good morning, everybody. Thanks for joining us for today's Cancer Survivorship Echo Clinic. This is the last in our series, so great to have you all. I recognize everyone here, actually. So I'm glad you joined us throughout this series. Bridget.
Yeah, absolutely. Well, thank you. Today we have a wonderful presentation with Douglas Heron. He is a physical therapist at St. Mary's Regional Medical Center. So first off, I'd like to kind of go back to why we're doing this series. It is a series to primary care providers as an introduction to issues in cancer survivorship. So more than 2/3 of those diagnosed with cancer are told that they expect to live at least 5 years after diagnosis. So this year alone, 14,810 people will be diagnosed with cancer. So this series really hopes to address survivors' ongoing needs with improved outcomes and quality of life for cancer survivors. So we really hope that all of you have found this series to do exactly that. This is the last in this series, and once again, thank you so much, everyone, for joining us. It's really been a great turnout, and we hope to do more of these in the future. So please leave your feedback, suggestions, any comments that you have about the series today. We greatly appreciate that. So to introduce Doug Heron, he grew up here in Reno, Nevada, but left the state for 10 years for school, and he did a 2-year mission in Germany before returning to the area. He attended UNR in BYU, Idaho, and Utah State before earning his master's degree in physical therapy from the University of North Dakota. During his practice, he began working with patients battling cancer and managing the ill effects which come from cancer treatments. So he earned his certification through the American Academy of Lymphatics as a certified lymphedema therapist. Besides working with cancer patients, Doug also developed expertise in many and diverse venues throughout his career, such as wound management, exercise science, manual therapy, teleeducation, and pulmonary rehabilitation. He created the pulmonary rehabilitation program at St. Mary's Regional Medical Center, along with the Better Breathing Support Group. He also created the first and only lymphedema support group within Northern Nevada. He has practiced as a physical therapist for over 20 years, and he's heavily involved in community service, scouting, and working with youth at the local congregation of his church. He's been married to his beautiful wife for 25 years and has 6 talented and handsome boys, which he considers his greatest accomplishments. So without further ado, let's welcome Doug.
All right. Good morning, everyone. And so I'd also like to go around the group here and see who we have joining us this morning. So we'll start off, Myra Garcia. Could you introduce yourself? Myra, go ahead. We should be able to hear you.
Hi, Myra Garcia with Access to Healthcare.
Thanks,
and
Myra.
I'm care coordinator, and I care coordinate cancer members.
Great, thank you. Kay Preciado.
Good morning, my name is Karina, and I'm also a care coordinator at Access to Healthcare.
Wonderful, thanks. Alan?
Okay, sorry about that. Yeah, I'm Alan Fisk. I do technical support, and this sounds like this would be great. That's the path my daughter's on at school, so I'm looking forward to this.
Thanks, Alan. And Dr. Barry Cole?
Good morning, Barry Cole, retired physician here in the community and cancer survivor too.
Thank you. Griselda Chapa?
Hi, good morning, everyone. My name is Griselda. I am a community health worker for colorectal cancer with Nevada Health Centers.
Wonderful, great to have you today, thanks. And last is Denise R.
Hi, good morning. My name is Denise. I'm with Access to Healthcare, and I'm also a care coordinator.
Great, thanks, Denise. So we'll get going with the talk for today, but if you have any questions throughout, please feel free to unmute yourself or write in through the chat box, and we'd be happy to address those. All right, take it away.
All right. Well, good morning, everyone. Thank you for taking some time this morning for this topic. So we're going to be talking about conservative physical therapeutic treatment options for cancer patients. And again, I'm a physical therapist and certified lymphedema therapist. So life-saving cancer treatments can have adverse side effects on anatomy and physiology of a patient's body and tissue, obviously. Cancer treatments such as surgical interventions, chemotherapy, radiation, other medical therapies can have their effect on anatomy and physiology, of course. So some of the adverse anatomical and physiological effects can include cancer-related fatigue and malaise, which I work on quite a bit, actually. Weakness from cancer treatments. A lot of times patients will have diminished balance, and also chemotherapy-related neuropathy, along with cognition deficits, affectionately known as chemo brain. There are soft tissue changes many times, scarring, increased soft tissue turgor, adhesions through surgical intervention, radiation. One of the common ailments that I see is axillary web syndrome or cording, which is thought to be non-patent lymph structures or venous structures, or also myofascial adherences or restrictions or tightening. And that can happen in the axilla, antecubital fossa, in the elbow, or even in the wrist, thoracic area, a lot of different areas. Range of motion limitations, common. Nerve entrapments, I see occasionally. Radiation, soft tissue changes, and then there's qualitative changes in the tissue with these cancer treatments. Lymphedema is a common one that I see. That's when there's mechanical insufficiency, when the lymphatics have been damaged. The lymphatic system is responsible for 10 to 20% of the fluid return back up towards the heart. And so when there's an axillary node dissection or other nodes that have been removed, then that disrupts that lymphatic flow. And so I see that quite a bit. Occasionally, wounds, complications related to function and performance of activities of daily life are common. Paresthesias or anesthesias are common. Other adverse side effects can include altered body image, hair loss. I have a special empathy for my patients that are going through that. Depression, anxiety, pain, decreased energy levels, decreased coordination. There are prostheses considerations, breast prostheses or wigs, that sort of thing, that people need to deal with. Occasionally there's sexual dysfunction, decreased general functions, inability to perform a job or decreased ability. Activities of daily life suffer. There's changing roles sometimes and dynamics within the family and relationships when a cancer diagnosis happens. There's financial stressors and a myriad of other different types of stressors, feelings of isolation and loss. So as a physical therapist and certified lymphedema therapist, I work commonly with patients before, during, and following a variety of cancer treatments, but most especially with breast cancer patients. I get a lot of referrals for breast cancer patients. During my assessment, I look for the following anomalies during the first visit. So strength, a lot of times that is diminished, and especially in the scapular muscles and postural muscles. Joint range. It should be joint accessory motion and range of motion. For normal physiological motion, we need a certain amount of accessory motion and joint play movement, and occasionally that is inhibited or impaired after these surgeries and treatments. Soft tissue flexibility, sensation, balance, all these can be impaired. Abnormal movement patterns and coordination. Neurological engram loss, that's a $10,000 word for basically the brain's ability to communicate to the muscles and the muscles' ability to communicate back to the brain. Anytime a person has surgery, sometimes they have to kind of get to know their new body a little bit. There are myofascial restrictions commonly, functional deficits. Again, the ADL limitations, soft tissue anomalies. The axillary web syndrome and recording that we've talked about, that can be either mild or severe, you know, in any place on the spectrum. And it's unfortunate too, because a lot of folks that don't get referred over to see me or my colleagues, they'll live with this axillary web syndrome for, you know, 5-10 years before they see us, and then wish they had come sooner, because we can really free them from that kind of straitjacket that they're in. Nerve entrapments, again, scar tissue immobility and restrictions, limb volume discrepancies, comparing the involved with the uninvolved side. Sometimes these the swelling with lymphedema can be kind of insidious, and so we want to kind of get a baseline measurement on that, just in case the swelling begins. And then, of course, look at the demographics to assess further resources and support that the patient may need. So typical findings in my assessment usually include anomalies or deficits with at least some of the aforementioned areas that we just talked about. So physical therapeutic intervention is helpful and restorative with many aspects of a patient's identifiable limitations. We develop individualized goals with respect to a particular patient's needs. An individual treatment plan is created to address the areas of greatest concern for a person's health and well-being after this devastating diagnosis. So physical therapy intervention. Though therapeutic intervention is helpful for many deficits, I'd like to address just a few of the major impairments that I commonly identify and treat. For some reason I have these in reverse order. I'll talk about cancer-related fatigue first, and then orthopedic considerations with patients that undergo cancer treatment. And then lastly, I'll talk a little bit about lymphedema and how to treat that. So combating cancer-related fatigue through skilled therapeutic intervention and exercise. So this is the way we treat cancer-related fatigue, is through exercise. And there are many, many benefits of exercise. I could spend 2 hours just on the benefits of exercise. Unbelievable amounts of benefits. Exercise actually reduces fatigue, anxiety, and pain over time, even though it feels like a person doesn't really want to start doing that right afterwards. Eventually it will be very, very helpful. It also reduces the risk of cardiovascular disease, type 2 diabetes, metabolic syndrome, and some cancers. Improves bone and muscle health, increases balance, flexibility, and mental health and function. Improves mood and increases ability to successfully perform activities of daily life. Potentially can increase longevity or quality of life, definitely. Assists a person in reaching their proper body mass index, which is important for a lot of reasons. Can regulate hormone levels, helps prevent obesity, improves immune system function, reduces inflammation, fights arteriosclerosis and atherosclerosis, improves gastrointestinal function, strengthens the muscle. Incidentally, this is the #1 indicator of a person's likelihood of being independent going into older years. If somebody wants to maintain their independence, they need to be strong. So strength training is extremely important. When we talk about lymphedema, there's some special factors we need to consider with strength training. Increased ventilation coordination. Other benefits, increased bone density. This can reduce compression fracture risk to the spine and other areas. Enhanced mood, endorphins are the long-acting chemicals, and enkephalins are short-acting. We just make us feel good. These are the chemicals that are responsible for the runner's high. When we exercise, we just feel a lot better. It increases our energy over time. Improves our posture if we're doing the right types of exercise. Improves coordination. It can help with blood pressure over time, assist with lymph and venous return and peristaltic action of the gut. Angiogenesis, this is a phenomenon that happens. It's amazing that the body has the ability to do this, but it actually creates new blood vessels to better respirate our individual cells. We have 10 trillion cells in the body, and as we exercise, these little blood vessels are actually created and infuse oxygen and nutrients into our cells more efficiently. So it's kind of analogous to a roadway system. Our body has the ability to create new side roads, if you will, to get the cells the nutrition that they need. And this is exactly why when a person comes to see me, they may start out on some arbitrary setting on a piece of aerobic equipment, and then all of a sudden, after a few weeks, they can do it twice as well. And that's partly because of this angiogenesis that happens in the body. It's not because the treadmill, for example, has gotten easier, but it's because they've built a better biomechanical machine. So increased ability for respiration because of the enhanced capillary system, like we talked about. This also bolsters the immune system, also probably because of angiogenesis. Fights depression. This is a very powerful antidepressant exercise. Assists with self-esteem. Also, blood cholesterol levels and triglyceride levels can be helped with exercise. So I just threw this body fat chart. This is basically to show, some averages for gender specific and also age specific. There's optimal fat mass that we should have in our bodies. Adipose tissue is releases hormones and can be a factor with cancer if we have too much adipose tissue in our bodies. So cancer-related fatigue and exercise. So this is kind of some interesting statistics here. Obesity has been linked to the increased risk of 13 different cancers. Exercise has been shown to reduce the risk of developing breast cancer in women by 12%. Body fat and weight gain before or around the time of diagnosis can increase the risk of recurrence and death in prostate cancer. Wow. Exercise has been shown to reduce the risk of developing colon cancer by 30 to 40%. Recent evidence shows that obesity is linked to the risk of cancer progression, which is pretty phenomenal. And then this one will make your jaw drop to the table. Studies have shown that exercise can reduce the risk of cancer recurrence by up to around 50%. Holy cow. Why is why is everyone not exercising after a cancer diagnosis with that statistic? Everyone should be exercising if they've been diagnosed with cancer. Most people have cancer-related fatigue. This continues after the cancer treatments. Should be managed from the beginning with the right exercise prescription and the right frequency and duration and type and intensity. Your local or your physical therapist can help a person out with that. Budgeting energy is important after a cancer diagnosis because we do have diminished energy. Planning, delegating movement, adapting to a new rhythm of life is sometimes important. So there's been much talk about target heart rates and trying to find out the right intensity of exercise, the Carbonin formula. There are other formulas out there. I've also read a lot of documentation on how that isn't a great way to figure out exercise intensity. The Carbonin formula and other formulas. There are a lot of individual issues with that. I much prefer the Borg scale, which is basically perceived breathlessness and exertion, because you can kind of feel how your body is handling the exercise. And so I I encourage my patients to kind of do a moderate breathlessness, moderate exertion on the Borg scale. And that correlates pretty well with the Carbonin formula and other formulas as far as target heart rates. A lot of times people will need to break up their exercise throughout the day because of the energy levels. Strength training, extremely important. This increases the metabolic rate, helps improve function, movement, prevents fatigue. Like I say, there are certain issues with strength training with lymphedema. A lot of times I encourage my patients to perform their exercises at lower load and higher repetition, so we don't create any inflammation. Inflammation is a protein-rich fluid. Protein-rich fluid is taken up to the heart only in one way, and that's through the lymphatics. Those protein molecules are so large they can't get into the venous system. So again, the American College of Sports Medicine recommends the following for adults: 150 minutes of moderate intensity exercise per week. That's what I try to prescribe for my patients. Again, when I prescribe an exercise program, I take into consideration the aerobic, anaerobic, flexibility, and balance components. So this can be broken up, again, moderate breathlessness and exertion, that's 3 and 3 on the Borg scale. 30 minutes is great. I think that gives you most bang for your buck. If you go longer than that, there can be some, the law of diminishing returns kind of rears its head if we exercise aerobically too long. However, if a person is enjoying it and they can do it, that's great, but try to shoot for 30 minutes. I try to have my patient's body be their guide. Again, a lot is going on in the body, chemotherapy and radiation, and so there are good days and bad days, and a lot of times they can do more one day and less the next, but progressively I want to see an increase, even though it might be sinusoidal increase, there's an increase nonetheless. So orthopedic considerations. This is, I deal with this quite a bit after breast cancer surgery and other surgeries. So typically there can be pain. This can be surgical pain, neuropathic pain, or chronic pain. A lot of times there's weakness post-operatively, and even pre-operatively. Sometimes people go into surgery a mess, orthopedically speaking. They're weak as kittens, and that's not a good way to go into surgery. You want to go into surgery strong, and you want to emerge from surgery trying to be as strong as you can. A lot of times there's muscle guarding after a surgery. There are range of motion deficits, soft tissue flexibility deficits. This can all be assisted with physical therapy, trying to get the joint play motion back, trying to get the physiological motion back, trying to get people stronger. So much of the time, generally, we're very tight and strong through the chest area, and we're long and weak in the back area. We also tend to have a chin poke posture because of all our computer work and everything else that we do. And so what we try to do, and then after a breast cancer surgery, it's even worse because then tissue is removed here. We have scar tissue. It's almost like a drawstring that brings people forward and even worsens that propensity to have thoracic kyphosis and chin poke posture. So a lot of the therapy that I do is I try to get people back, the shoulders back, the chin tucked, the head back on the shoulders, strengthen the scapular stabilizers, stretch out the anterior musculature and scar tissue and other things that they're dealing with. So again, body image and functional changes occur. These are all things that we try to improve upon after their surgery or radiation. Radiation a lot of times changes tissue on a cellular level, and so the tissue has a different feel to it. It has an increased tissue turgor and increased collagen versus the elastin fibers. And so we're trying to, and they, that tissue will stretch out, but a lot of times it just has to be time under tension. And so we have different ways that we rehab that through myofascial release and mobilization and scar tissue mobilization and stretching, nerve flossing, other things that we do to try to get that tissue to move again. I look for soft tissue restrictions. This picture here shows a pretty good example of what what axillary web syndrome can look like. This is in the antecubital fossa here that you see this, but you can also see right here, maybe I'll move the little dot over here. So maybe a little bit in the wrist. Obviously, you see this here in the antecubital fossa in the axillary area. You can see a little bit also when you put your hands on a patient, you can actually really feel this tight cording underneath the tissue. As you go deeper, you can feel different layers and how tight they are and how restricted they are, how they don't want to move and slide and glide next to their neighbor quite as well. And then this can be helped through manual therapy. So orthopedic considerations continued. So scar tissue can also adhere to adjacent structures and cause immobility. And what happens is the scar tissue isn't just what you see, but it goes down deep in through the tissue, almost like a shower curtain or something. And nerve and vascular structures and other structures need to pass through the scar tissue. And again, this has more collagen fibers, less elastin fibers. It doesn't want to stretch and move as well. And so the perception from the patient is that they're wearing, kind of a tight vest or maybe a shirt that's real tight that's tucked in wrong, and it's just always pulling on them in a weird way. And so a lot of my therapy is to go in and actually to help mobilize that tissue and get that tissue moving so that that tight vest feeling isn't there anymore. It's amazing. Sometimes it's really difficult to get that range of motion and soft tissue mobility back, but occasionally, just after one session, somebody can get full range of motion, and there's lots of release in the myofascial tissues, and it's unbelievable how quickly it can come back. But a lot of times people just don't know that they can touch their scar and that they can move areas that are painful. And when we start doing that, then they realize that, oh, I do own this part of my body, and I can actually work out. I can touch the area. I can stretch the area. This isn't going to hurt me. And then, of course, this is all with proper intensity and dependent on how long a person is out from surgery, that sort of thing. And so we kind of guide our patients with that and try to help them to know to what degree and intensity they can do this therapy. So again, it's important to see a physical therapist certified in lymphatic therapy who has expertise in treating these conditions, because these are specialty conditions that we're talking about. Ooh. Okay, so we talked a little bit about the treatments. This is a good example of axillary web here. Again, I do take a variety of techniques. Some of them are listed here: myofascial release, myofascial mobilization, scar tissue mobs, soft tissue mobs, stretching, neural flossing, cupping. Michael Phelps made it famous in his Olympic debut, where he had a little crop circles all over his back, but physical therapy was doing it before it was cool. So it's basically just creating that tissue stretch and holding it to time under tension for a long period of time. A lot of times I'll do non-thermal ultrasound if there's a glenohumeral joint impingement or subacromial bursitis or something like that, in addition to their myofascial restrictions that they have from the surgical intervention. Proprioceptive neuromuscular facilitation is usually done with neuro, but I integrate that in because, again, we have to kind of get to know our new bodies after the surgery. Temperature modalities, normally ice. I don't necessarily like to use heat because that invites congestion, tissue congestion, and that puts a heavier burden on the lymphatics. And so a lot of times, after treatment, we may use ice or NSAIDs if necessary to help with any pain or discomfort from the treatment. Exercise, of course, we use in a lot of different forms, joint mobilizations and combination techniques. So let's switch gears to the lymphatics here. And if any of you have questions as we go along, please just jump right in. That's fine. The lymphatic system is part of our vascular system. Okay, so we have the arterial system, we have the venous system, and then we have the lymphatic system. And the lymphatic system has actually been a little bit of the forgotten stepchild over the centuries. Really, it's only had recent attention, maybe starting about the 1960s, both in Germany and in Australia. They started working with lymphedema when there's a problem with the lymphatic system, and started developing treatments, and then that spread through the world. So it's happily we have treatments for lymphedema, but the lymphatic system is pretty complex. It consists of initial lymph capillaries, precollectors, collectors, lymph nodes, lymphangion ducts, trunks, and angles. There's also something called the cisterna chyli, which is a little reservoir of lymph fluid right behind your navel. Lymph structures are found throughout the body. Nodes are heavily represented in the cervical, axillary, and inguinal areas, however, are found throughout the body. Lymphedema is a progressive mechanical insufficiency of the lymphatic system, which causes an abnormal amount of protein and water to accumulate in the interstitial spaces in the lymphatics. And again, the lymphatic system only takes up about 10 to 20% of the fluid return back up towards the heart, but it's extremely important because the venous system just cannot take that protein-rich fluid, which is found in inflammation and other metabolic processes that happen in the body. So the World Health Organization's the World Health Organization estimates over 250 million people suffer from lymphedema worldwide. So that's a lot of folks. So again, the lymphatic system, it's kind of the forgotten system. It's featured here in green. The lymphangions are, they're like little pack bend structure in a ganglion chain, and they're lined with smooth muscle. And so they'll actually undulate at a certain rate and rhythm, and will actually push that fluid back up towards the heart if everything is working correctly. But the lymph nodes are kind of like train stations, and you have many lymphangions that are actually coming into those lymph nodes, and they're like the train tracks. And so if you can imagine plucking out a train station, and then all these, lymphangions are trying to move that lymph fluid, but they have nowhere to go now. It's just they meet scar tissue where a lymph node once was, and so it's a lot more difficult to move that that protein-rich fluid. So that becomes a problem occasionally. This is an example of what lymphedema can look like. Obviously, she has it there on her right arm. There's primary lymphedema or secondary lymphedema. Secondary lymphedema is basically, a protein-rich fluid, a mechanical insufficiency that's happened because of some sort of trauma. Primary lymphedema occurs because sometimes we, congenitally speaking, we just are born with too few or lymph nodes or lymph structures. So with primary lymphedema, there's congenital type. This is before 2 years of birth, such as in Milroy's disease. Lymphedema precox, this is the majority of primary lymphedema that I see. This can be because of hypoplasia, hyperplasia, aplasia, or lymph node fibrosis. For example, a gal came in to see me, 21 years old. I never knew she had a problem, and she was just in the weight room, caused a little bit of inflammation because of her exercising. And her arm started to swell, never had any breast cancer or anything like that. But she would be a good example of this lymphedema precox. Then there's lymphedema tarda that occurs after 35 years, again without an incidence of trauma. With secondary lymphedema, this is a mechanical insufficiency. Typical causes include, of course, surgery. Radiation can also cause lymphatic tissue damage. Infections are also a big one, cellulitis and things like that, especially in the lower extremities. I see that a lot when people have had a couple of cellulitis bouts, then their vascularity can be disrupted, and that can lead to chronic venous insufficiency or other problems such as lymphedema. This can be complicated by congenital lymphatic malformation or chemotherapy, obesity, or lipedema. Lipedema is different than lymphedema. This is almost exclusively found in women. They just have a greater propensity for adipose deposition out at the hips and upper arms, and this can be a complicating factor for lymphedema. There can be malignancies and other problems that can complicate lymphedema as well. So obviously these can get really, these limbs can become really a challenge. This is stage 3. There's 4 stages of lymphedema, 0 through 3. This is the last stage, elephantiasis. So with our lymph system, we have a lymph carrying capacity, all of us do, from birth. And by the way, we talked about angiogenesis, how we have the ability to create new blood vessels. Unfortunately, the body does not have, however, the ability to create new lymph vessels. It can repair existing lymph vessels, but it cannot create new lymph vessels. So that's why it's such a big deal when lymph nodes are removed. But of course, they have to be for life-saving measures with cancer treatments many times. But some of us are born with many and quite a reserve, and some of us are born with few. And so we don't know really if 3 lymph nodes is a big deal or if 10 lymph nodes is a big deal. It kind of depends on a person's genetic makeup. But if you see the graph there on the right side, lymph carrying capacity is in blue and lymph load is in orange. So the lymph carrying capacity, usually we have a big functional reserve. That's the FR on the right side there. And then there's no problem. As you know, if we get stung by a bee, or we hit our hand on the coffee table, or there's some trauma otherwise that happens with our tissues, that we have a little bit more inflammation or metabolic activity in the tissues, no big deal. We have that functional reserve. That lymph load can go up and down, no big deal. But when a person undergoes cancer treatments, a lot of times that blue cylinder there, the total capacity, will actually reduce and come close to our lymph load. And until the balance tips and the lymph carrying capacity is below the lymph load, we don't notice a problem. But now all of a sudden, the scales have tipped just a little bit, starting to not be able to see my metacarpals in my hand, metacarpal bones in my hand so well anymore. I feel kind of this fullness in my arm. And that can happen, and in fact, has kind of an insidious onset. Even 1 year post-surgery, only 50% of the folks that will develop lymphedema have already developed it. So in other words, 50% of the people that will develop lymphedema will develop it after that first year. And even after 3 years, 25% of the folks that will develop lymphedema will not have yet developed it. So there's always that risk. It never quite goes away. And so that's why there are risk reduction techniques and strategies that we teach our patients once they've been through these surgeries. And that's why, in my opinion, every individual that has undergone surgeries that have removed lymph nodes, cancer-related surgery, should be referred for this reason, if nothing else, but to teach them risk reduction techniques. And that's why a person shouldn't have a blood pressure cuff on that limb, or needle draw, or blood draw, or a vaccination on that side, because we want to really reduce the risk of inflammation on that side.
I have a question.
Yeah.
So sorry to interrupt, but to that point, is that something, and I just know within other breast cancer survivors that I've spoken to, that there's kind of this myth about that you're supposed to not have your blood drawn from, you know, whichever arm you've had lymph nodes removed, and that it's only for a certain period of time. So is that true, or is that something that you have to do for the rest of your life?
Right, that's a great question. You know, and it's individual. It's a difficult question to answer, because is this blue cylinder large in person A's case, or is it very close to the orange cylinder? We don't really know, because if it's just barely over that orange cylinder, there's still no swelling, and so we think we're just fine. And so we don't want to have something like you know, a blood draw on that side be the straw that breaks the camel's back. Okay. They may have lots and lots of functional reserve. We just don't know it. Mm-hmm. So it's not a bad idea just to kind of be aware and cognizant of that side, and just be a little bit more careful than you would. The longer you go without an issue, the more likely you won't develop lymphedema on that extremity, and so that's good news. But the risk is always there as we age. Our vascular structures, everything, our arteries, veins, lymphatics, along with all of our other tissues, don't work quite as well, you know, as when we're younger. So you know, even though it may not be an issue now, maybe in a decade it could be an issue.
Thank you.
Yeah. Any other questions? You're welcome to just ask away. So lymphedema continued. So again, 5 million Americans are living with this progressive yet manageable condition. It has a gradual onset, develops slowly, worsening over time. And this is important. Symptoms may come as a sinusoidal wave, appearing for a time and then resolving. This can be misleading to the patient, as if everything is okay when it's really not. And this happens a lot. People will say, well, you know, I've been kind of dealing with this swelling for years, kind of comes and goes, but now it's kind of come and it's kind of stayed. And really, they needed to nip it in the bud when it happened initially, because otherwise then we have to, instead of a compression garment and a sleeve, or a sleeve and a glove, or a gauntlet, and they're in the maintenance phase, now all of a sudden we are in the intensive phase, and we have to really work that fluid out of there with short stretch wrapping. This is an example of that. Fingers and the arm are wrapped here. And there's techniques. It's called complete decongestive therapy, and how to treat lymphedema that's gotten out of hand. We'll talk more about that. But there's stages of lymphedema, 4 stages. Stage 0 is when that lymph carrying capacity still has not yet met that orange cylinder, the lymph load, right? So we have not seen any swelling, but the person is still in stage 0 because they have had an insult to their lymphatics, so they're considered stage 0. Stage 1, now all of a sudden, we have had swelling, even just a little bit of swelling. Stage 1, it's typically reduced with elevation. There can be some pitting involved with that. Stage 2, the hallmark on that is when the swelling doesn't go away quite as well with elevation. Sometimes you get a little bit of fibrotic changes with stage 2. And then, of course, stage 3, there's fibrotic tissue and indiscernible pitting. We've seen a couple of slides a while back on this with the elephantiasis. It can get extremely large, the limb. So again, don't wait. Risk reduction and education is extremely important. Again, I wish that more people were referred post-cancer treatments to us, because it's really important information. And a lot of people too, going back to the orthopedic issues, a lot of times they really don't realize that they even have a range of motion issue, but when they're put into thoracic extension and a little bit of shoulder abduction or flexion, then all of a sudden in range, oh yeah, I guess I do have a problem. And people just kind of live with that, and it's not in the forefront of their mind until they're trying to take out a dish from their cupboard or something up overhead, and then it reminds them. But we want to have a good, well-functioning body. So, all right. So, yeah, the risk never entirely goes away. Generally, though, within 5 years, that is a really, really good sign. And it's always in the affected quadrant, by the way. You'll never develop a lymphedema. If you've had a right axillary node dissection, for instance, you're not going to have lymphedema on the left. That's related anyway to that surgery. So these are some specialty issues. Malignant lymphedema. These are troublesome, and these are difficult. Malignant tumors. These are tumors that are causing pressure or blockages on the lymphatics from the outside. Malignant lymphangiosis. This is actually what happens when the malignant cells are blocking the lymphatics from the inside. And then you can have also an angiosarcoma, such as in Stewart-Trave syndrome. That's featured there on the right. And this is a rare deadly angiosarcoma that arises in the setting of a chronic lymphedema. And this is most commonly seen after breast cancer surgery or axillary lymph node dissection. Rarely seen in the lower extremities, but this is a really bad diagnosis because the survival rate is very poor. And again, so the treatment for lymphedema, again, in Germany and Australia, at the same time, they were kind of developing these techniques in the 60s. They've developed complete decongestive therapy, and that there's a lot of tenets with complete decongestive therapy, but this is what most people need. There's manual lymphatic drainage, which is a type of massage that I do, which has certain rate and rhythm about it, certain sequences of what needs to be massaged first and second, third, that sort of thing. The lymphatics are quite superficial. They're right in the subcutaneous tissue. So it's actually a very light massage. Let's say if somebody's arm is swollen, a lot of times you might think, oh, well, I'll just start at the hand and kind of move things up. No, we like to clear things proximally first, do a lot of core work to allow room for fluid to flow. So we don't want to push fluid into more fluid. We want to vacate the area where the fluid is actually going to be going. Everything eventually dumps into subclavian vein, right and left. In fact, it's interesting, we're a little bit asymmetric that way. The left subclavian vein takes care of both lower extremities and the left upper quadrant, whereas the right subclavian vein takes care of only the right upper quadrant, which is kind of interesting. But at any rate, so there are certain ways and pathways and watershed areas that we use to divert this fluid to unburden what we consider the blocked area. And so that's what manual lymphatic drainage is about. Please.
I have another question. So does it depend, do you see that women that maybe have had surgery on the left side versus the right side have more of, maybe the left side, they have an increased risk for lymphatic because it's
a busier area?
Yeah, or the right side? I'm just...
It's a really great question. I haven't actually seen that. I've seen kind of equal amounts of difficulties from left to right, but granted, it is a busier place, having to deal with all of the lymphatic fluid from the bilateral lower extremities. You would think that you would have more issues if someone had a left cancer removed, but it doesn't seem to be the case. And I don't know if that's because, when we get up to that area, if perhaps that trunk or duct is a little bit larger. Maybe it's an 8-lane freeway instead of a 6-lane freeway. I'm not sure, but yeah, it seems to be equal. It'd be a good topic for a study, though, because that's just me shooting from the hip.
Right.
But yeah, if a person puts some statistical data together, maybe we could answer that question.
Interesting. So there's not a lot known about the variation in lymphatic systems on an individual basis, and how, to your point, you said it was kind of the forgotten.
It is. There's much more information now, and much more interest in the lymphatics over the last maybe 60 years. But yeah, there's still not, still the gold standard for impairments with lymphedema is this complete decongestive therapy. There are surgical procedures that are being trialed with limited success. And even though some of my patients have gone through some of these surgical procedures, they've still needed the complete decongestive therapy. It doesn't, they try shunting the lymphatics to the veins and different things. But Dr. Roxon, I believe he's at Stanford, he's kind of on the forefront of that. And there's some other surgeons throughout the country. But at this point, CDT is the therapy of choice. So then there's compression therapy. This is vital. This is probably the most important component of CDT. Why? Because you can't, give yourself manual lymphatic drainage 24/7. We teach the patients how to do this at home, but you can't do this when you're sleeping. You can't do this all day long. But a person can wear compression, 23/7 or so. And so, depending on where they are in the intensive phase or in the maintenance phase, if we need to reduce the fluid, that's analogous to having like braces, versus when you're in the maintenance phase and you have the compression glove and sleeve, that's analogous to like having just your retainer. So the retainer, the glove and sleeve is just going to maintain. The wrapping is actually going to reduce. Okay, so we have short stretch multi-layered wrapping is what we use, and that has been shown to be the most effective for improving lymphatic return. Again, there's a whole art and science with the compression therapy. What we're doing is we're increasing interstitial pressure within the tissues, and that affects something called Starling's equation, which basically tells fluid in the body where to go. And interstitial pressure is actually one of the components of the Starling equation, and so we're affecting that. Good skin care is a component of complete decongestive therapy that we teach the patient. Obviously, exercises. There are certain exercises which are very helpful. Movement patterns. Basically, anytime you have a mechanical deformation of the tissue, that stimulates those little lymphangions to move and undulate and push that fluid where it needs to be. That's why manual lymphatic drainage works, because we're causing a mechanical deformation of the tissue. That's why exercise works, because we're creating this mechanical deformation of the tissue. The body doesn't work well if it's stagnant. You might have noticed on a long trip in a car, you look down at when you get out at the gas station and your ankles are swollen. And that's because you haven't been moving. The body relies on the muscle pump effect for not only lymphatics, but for the venous system as well. And that's why, incidentally, just a little plug for compression stockings or travel socks. Everybody, in my opinion, over probably 50 should be wearing travel socks when they travel. People die of deep vein thromboses all the time because of coagulating blood. It happened to a friend of mine 2 weeks after she retired. Isn't that terrible? Didn't get to enjoy her retirement because of DVT when she was traveling in a car. So anyway, exercise really does help push fluid where it needs to go. It causes that mechanical deformation. Those little lymphangions will undulate at a certain rate and rhythm and push that protein-rich fluid up and out of the tissues, back up, like say to the what we call the terminus. Again, I like lower load, higher repetition exercises for people with lymphedema to lessen the risk of inflammation. There's also devices out there that are available, intermittent pneumatic compression pumps. Those can be very helpful to kind of move fluid. It's a sleeve that you put on, and it's compressed with air. They have them for the lower extremities as well.
They have them after you go through surgery, right?
Also, those are a form of pneumatic compression. These are a little bit more advanced. They're a little bit more smart machines, $5,000 and up, but they sequentially actually move that fluid. So the same principles that apply with manual lymphatic drainage. A lot of times they'll decrease the congestion proximally, and then kind of work, proximally as they're working downward, if that makes sense, or as they're working distally, they're pushing the fluid proximally, and so they can be very helpful. But again, they're just an adjunct to CDT because you can't have, usually an hour a day is the recommendation on that, and a person can't, schlep that machine around with them all day long. So, but it is helpful for a lot of folks. Everybody has swelling in different places too. I mean, I've had patients where their swelling is just in the breast. Some people are just in the trunk. Some people have it just in the arm or just in the hand. So it kind of depends, and the treatment has to be kind of individualized because of the individual type of presentation that everybody has. Again, education, risk reduction techniques, that's huge for this population. So that's pretty much all I have, unless there's any questions.
Okay, do we have any questions out there this morning? All right, do you want to talk about the
Yeah,
summit
if you
real
could
quick?
put the summit up,
Okay.
that'd be great. So once again, thank you everyone for participating in today's webinar. It was wonderfully informative, and I learned a lot, so thank you. So please mark your calendars for our upcoming Nevada Cancer Control Summit. It is on September 16th. So it's going to be a one-day statewide conference featuring wonderful presentations, such as Doug's presentation that he did today, targeting topics across the cancer spectrum. So please go to our website to learn more about the summit, and you can register there. It's going to be a lot of fun. It will be here in Reno at Whitney Peak Hotel. And thank you so much, everyone, for joining us today. And if you have any feedback, any suggestions, please shoot me an email. And you can find my email at nevadacancercoalition.org. So thank you so much.
Thank you, everyone.
Have a wonderful Memorial Day weekend.